All right, so I'm just going to start now. So once again, good morning. You're welcome to this. We are the home stretch, and this is the third webinar in a three-part series we started 2 weeks ago on Radiotheranostics. So today we'll be looking at infrastructure, training, and implementation in Nigeria. Actually, Radiotheranostics has already been implemented in Nigeria, but we're just going to discussing today how to scale up. So just quick housekeeping as usual. If you have questions, we have a panel today. And if you have questions for them, please put them in the chat. And just remind us again that you are entitled to receive a certificate upon request, and you can send that email to communications@medicatecancerfoundation.org. I'll be your wonderful moderator today, as I was for the last two series, and I'm Yobosa Wadiai. I'm a medical physicist by profession, and I'm also privileged to be leading the Nigerian Association of Medical Physicists. This webinar, like the other two, was organized by two wonderful foundations, Onsidium Foundation and Medicaid Foundation. I'm not going to spend too much talking about them, but I would like their representatives to please put their web links in the chat so that we can find out more about them. Medicaid is Nigerian-based, and Onsidium is an international-based foundation. Today, okay, I already mentioned this. I'm just going to skip this. So this is our agenda today. We will start by giving a brief overview of the last two webinars, just to bring everyone up to speed, especially if you are not here. And that will be done by Dr. Orunmuyi today. Then we'll have our panel session and finally our closing remarks. So Dr. Akintunde Orunmuyi is a consultant nuclear medicine physician currently at the University Hospital Southampton, NHS Foundation. He's also a scientific advisory board for Onsidium and one of their ambassadors. He was also one of our speakers at the first webinar. And he's going to be on the panel too. So our second panelist is Professor Abidemi Omonisi, who is the president of the Nigerian Cancer Society, is a pathologist and a cancer control advocate. I would like to congratulate him. He was just elected for the second time as president of the NCS. Our third panelist, Dr. Mahipa Rathod, is a nuclear physician, is a nuclear pharmacist, I beg your pardon. He's a board-certified nuclear pharmacist. He was our speaker last week, so he'll be joining us again today. Professor Musa Ali-Gombe is Director of Clinical Services at the National Institute for Cancer Research and Treatment. He's also a trained radiation oncologist and a national cancer control leader. He'll also be joining us. And we have Dr. Samuel Gitau, who is a radiologist and a nuclear medicine physician from the Aga Khan University Hospital, Nairobi, Kenya. So he'll be bringing perspectives from that region. So we're going to be discussing several topics: system change, radiopharmacy, financing, national strategy in infrastructure, workforce, and advocacy. So basically, the how-tos, how do we implement all that we've been discussing? What are the barriers? What are the challenges? How do we overcome them? So like I mentioned, we'll take your questions as soon as they're done speaking. I'm quickly going to invite Dr. Akin, who will quickly give us a brief overview of what we've been discussing so far before the panelists join us. So thank you very much. Dr. Akin, can you please share your screen?
Thank you, Yobosa, and good afternoon to everyone. Can you see my screen?
Not yet.
Okay, so I would like to thank the organizers of this event, Medicaid Cancer Foundation and Onsidium Foundation, for organizing what has been 3 weeks of talking about RLT. And this slide is just to open the discussion and serve as a refresher for those who were not here previously. I have
we can't see the slide. Are you sharing already?
Yes, I am.
Sorry, can somebody else confirm in the chat that you can see his slide?
Yeah,
Maybe
we
I'm the
can
only one.
see the slides.
Okay,
Oh, you
so
can see. Okay, that's
some
fine.
people can see, some cannot.
Okay,
All
that's
right.
fine then. Okay, that's fine. I'm the only one. Don't worry. Just go ahead, please.
So I have no conflict of interest to declare. And if you've been hearing about radioligand therapy, the question is, what exactly is radioligand therapy? And I like to use MAP and ZAP. MAP means we can map out and identify where the disease or the target is. And then ZAP is just like how you zap or destroy something. And it's a form of molecular radiotherapy where we try to identify a biological target, usually a receptor that's expressed on the cancer cell. And once we map it, we can use imaging to identify if this cancer cell expresses that receptor. So we can use PET or SPECT to see where the disease is. And then we take the same molecule and attach a different radioactive agent to it, usually a beta or alpha emitter, and give the patient. It's usually administered as an injection. But the earliest form that we may be familiar with is iodine therapy, which can also be swallowed. And that basically attaches to the tumor and destroys it. So it's very simple. The science is a bit elegant, but the delivery is quite straightforward. And in Nigeria, so I used to be in Nigeria. Every time they introduce me as someone in the UK, I'm like, oh, is that me? But yes, my journey started in Nigeria as far back as 2015. This was the aspiration. And at that time, I worked in Ibadan, which was the first nuclear medicine center, still is the first nuclear medicine center. And I got them to expand the beds from 2 to 12. And people say 12 beds in a ward. No, 12 dedicated rooms, shielded and ready, call them VIP rooms sort of thing. And this was 10 years ago when nobody was talking about radiotherapy, radioligand therapy, but sort of the vision was that in a few years' time, this would be one of the major ways of treating cancer. And so today we have 3 private nuclear medicine centers. As at 2019, it was just Ibadan and Abuja. And so once you see that 3 centers are coming on board, it shows that we're saying something and we're getting the message out. Nigeria probably needs about 10 centers to cover the vast geography of the region. And then early this year, we organized the Act Now session, which basically brought 22 stakeholders together to talk about the same things or some of the things we're talking about so that we can have more patients receive this treatment somewhere else, apart from these 3 centers. The characteristic of Nigeria is it's amazing that such a huge country, we're still talking of setting it up, but it doesn't mean we don't have patients and it doesn't mean we don't have needs. So to make this treatment possible, we need to collectively build the clinical pathways, so build the supply chains and build the institutions that will provide these treatments. And just to say how far we've come from the first treatment. So in 2015, Ibadan, this is just one center. We don't have data from the private centers, but I guess they've done a couple as well. But Ibadan, this is thankful to Dr. Kolade. He's on this call, Mayowa Kolade. He's one of the bright ones to watch. And in 2015, we had 15 treatments. And in 2026 alone, we've gone more than 50% of the entire of 2025. Thankful to Oncidium, out of the 37 treatments, 6 of them have been supported by Oncidium. And then we've been able to cover both lutetium and dotatate. I've not added iodine here because I think it distracts from what we're trying to achieve. We've mastered iodine, that's fine, but this is new and it's probably bigger than iodine. So this is where we are, and we're hoping with the support of everybody on this call, we can advance this. And that's why I've called this between spade and grade. A spade is calling a spade a spade. Let's be clear about what's working, what's not working. There have been constraints in terms of logistics. Cost is not a cheap treatment. And sometimes you hear the argument of, oh, how many cases of malaria will this treatment cover? But there are more expensive treatments that we're using today, especially in the field of chemotherapy. So if you look at it, the advantages and the benefits are something we should think about. And this idea of competing, trying to outdo one person has not worked for anybody. Globally, the language is collaboration, and thanks to Oncidium for bringing people from the US, from Kenya, from any part of the world to really help us, and let's do this together. And to make the grade, that just means we have to attain the same standard. So we've moved it from possibility, but we want to get it to the standard where it's routine care, where it's available, it's affordable, relatively affordable, where we're collaborating to do this together, and where we can do this at scale. So we're not just talking about treatment today. My panelists, please, let's think about how can we make the system work. I think if Nigeria gets it right, the rest of Africa will, well, not follow, but get it right as well. So this is just a quick teaser into the session. I'm going to hand you back to Dr. Yobosa to continue with the panelists. And thank you for the opportunity once again.
Thank you, Dr. Akin, for that very short overview. And I'm happy that you also highlighted the success we have achieved in Nigeria, because after the call last week, a lot of people were asking questions and commenting, is Nigeria not doing this? After hearing from the experience in Ghana, but we are actually doing very well. But today we want to see and know how we can do more. So I would kindly like to ask our panelists to please turn on their cameras if they can. And I don't know if Thais and oh my God, I just keep forgetting his name. I'm so sorry, please. Like if you can please spotlight them so they can show on the screen. So that's Professor Ali-Gombe, representing the Nigerian Institute for Cancer Research and Treatment. Professor Abidemi Omonisi, the president of the Nigerian Cancer Society. Dr. Samuel Nguku from Kenya. Sorry, let me just be sure. Dr. Rathod, from the US. So he has experience in Ghana, so he's going to be speaking for and of course, Dr. Orunmuyi. So the panel is kind of colorful. We have a pathologist, we have a radiation oncologist, we have a radiologist, we have a pharmacist, it's a very colorful panel. Okay, so I'm just going to go straight for the jugular. Please, if you have your questions, please put them in the chat. But we have a few questions that came up from the last two sessions, which we are going to use to break the ice. So I'm going to ask Professor Omonisi and Professor Ali-Gombe. Let's start from the known to the unknown. What are the biggest barriers to scaling national cancer capacity? Maybe anyone that wants to start first, or do you want me to specifically call your name? Okay, let's start from Professor Ali-Gombe from NICRAT, Director of Clinical Services. What are the biggest barriers to scaling national cancer capacity? After which Professor Omonisi would give his own comment on that.
Thank you very much, Dr. Yobosa, for also thank you for the invitation. Well, this is actually multifaceted. These include things like infrastructure gaps. We know that there is a wide gap in nuclear medicine infrastructure across the country. There is also uneven geographical distribution of these services. They are located only in big cities, and it's very difficult for the people at the periphery to reach that. And very important is also the shortage of specialized manpower. The few nuclear physicians and pharmacists, radiographers that we have and nurses have been disappearing, so to say. And then of course, it's the other issue with basically any machine that we have in this country and or any program is the issue of maintenance and also liability. So, and also there is issue of fragmented supply chain, since we need some consumables for some of these procedures, and then they are not readily available. So what is also lacking, and that is why NICRAT has been created and is supposed to do, is coordination. There is also lack of central coordination, so that all these things are well taken care of and coordinated at the center. And another very important factor which I want to mention lastly is actually about financing. Whatever you do, you need funds for these things, and these are very expensive projects, and they are capitally intensive, and sometimes resources are not readily available for you to execute that. And basically, I think we also need to streamline maybe the referral pathway, such that patients that require these things are navigated to the appropriate centers for this procedure. Thank you, and over.
Okay, thank you. Professor Omonisi.
Yeah, thank you. Thank you for the invitation, and thank you for having me. Well, I think I will start by saying the issue of advocacy is very important, because anything we do in our country, we must bring to the attention of the authority. You have a brilliant idea and you are working in silos, and the government is not aware of it. I'm sorry, you may just be working alone. I know there are quite a number of initiatives in the past that people have mooted, and until their well-coordinated advocacy, and involvement of all stakeholders before you have, a specific policy direction in that regard. RIT is not new. I'm happy Dr. Akintunde mentioned that, USH Ibadan have been in front lead of this for many years, and they've done their best, but the national uptake still remains a very important issue. And subsequently, there were advocacy from UCH. I know a few of them that have been in front lead. Federal Minister of Health, start looking that direction. Now we have more center now, trying to also, dive into that, arena. So I think advocacy is very important. Nigeria is a very big country, population almost 300 million. We are not the richest country in Africa, in the world. Even in the US, they are also, financially constrained. So the government have a lot, that they're actually dealing with. So it's a matter of priority. And now you can make your case before the government. I know for some years, this issue of radiotherapy was a major challenge that we have patients even flying to Ghana to have radiotherapy. But stakeholders came together and there was a robust advocacy. And now in our country, we have all the geopolitical, region. We have Center of Excellence, where government has, currently building and also upgrading the infrastructure. 3 have been completed and 3, yet to be commissioned. So I think advocacy is very important. I will encourage us, and this we are starting from somewhere, this public lecture. We should have a coordinated, advocacy. Then, the issue of policy is also very important. There's nothing you do in the cancer space if not back up by appropriate policy. You're wasting your time because funding by government is based on, policy, actually, and we know in our country, Prime Minister of Health is one that started ended up with policy in health, particularly cancer, policy in the country. The previous cancer, control plan actually does not contain ART that I'm aware, but the recent one, 2026 to 2030, that was unveiled by the Honorable Commissioner of State for Health on the 4th of October 2026, actually reflected that. So in our contrast of today, we have policy basis to implement ART and also scale it up in the country, because that was well captured in the new cancer control plan. So I think we are making progress. Once it's captured now, what we need now is a robust, policy, advocacy, so that there can be appropriate, funding, because that you have something, as policy doesn't mean that government will fund it. So we need that coordinated, advocacy. I'm happy that major stakeholders are in this meeting. We need to work together as a team, and see how to engage the Federal Minister of Health, because that is where the action is. We should not see what I said. Anything that have to be the budget, the health sector in the country, like there, So, and with that robust engagement, I'm sure that things will be better. Thanks, Anova.
All right, thank you very much. That's why we have you here. You're talking about policies, government. You are the government we know. NICRAT is the government we know. So hopefully at the end of today's meeting, we'll come with a solid, tangible conclusion on the way forward. And we'll have a question for Dr. Nguku from Kenya and Professor Ali-Gombe again. I'm coming back to you. But before then, Dr. Rathod, last week you shared experience from Ghana and all that. So how important is investing in radiopharmacy?
I think radiopharmacy, yeah, it's a great question. I think we're investing in radiopharmacy is a really high priority. What often gets missed is the infrastructure that may be needed on the ground floor before you can scale. But I think rightfully so, it's a blind spot only because the workings of an area like a radiopharmacy or a hot lab, they're behind the scenes, right? So no regulator is going to know or tour or traverse that space. So I think as folks who work in the nuclear world, I think part of our charge is to inform and educate those that are making the decisions, that certainly the executives, policymakers, health agencies, like, for example, if we spoke about Ghana, the Ghana Atomic Agency, they were, I think, early on less of a position to be able to speak to this. But I think by way of conferences like Warmth and ICRT, and the engagement of the on-sitting ambassador there, Dr. Hammond, I think that was the bridges that needed to be built. I think one thing you can take to your advantage on the policy side is if the agency is not regulating down to the molecule level and they're just allowing you to permit human use of isotope level licensing, but that's actually to your advantage because you can overregulate and then constrict the pathways for the flow of radioactive materials that are ultimately destined for patients. And then the other barrier that is notable is importation of isotopes and drug into the countries. So I think going back to the radiopharmacy piece, it is kind of an anchor. If you really want to create a hub and spoke model, your service footprint is the combination of, you're at the mercy of the physical half-life. We cannot influence that. That is something that's fixed. But however, the locus of delivery from the origin point, a lot of factors at play. And the more advanced the radiopharmacy is, the more pliable you are, and the more strategically it's located. You can service multiple centers if you have it well placed. And I think that's a geography question. And of course, no two centers or no two countries for that matter are configured alike. So I think these are all cogent points. And I think the other panelists raised some really important key factors. And all of it has to work in concert. I don't think there's any single one of these can be prioritized or deprioritized.
All right, thank you very much. Professor Ali-Gombe and Dr. Nguku, maybe I'll start from the same question, but Dr. Nguku is coordinating the Radiotheranostics project in Kenya. So maybe he will share his experience and then Dr. Ali-Gombe will just top it up for us. So what national coordination, because we need to coordinate this nationally if we're going to make any headway and scale up, what national coordination mechanism is needed for predictable supply of radionuclide? And then what role has the regulatory authorities played to ensure radionuclide supply becomes predictable rather than something individual hospitals have to solve independently? I'd like to hear from Kenya, then Professor Ali-Gombe would tell us how we can do it here in Nigeria. Dr. Nguku.
Thank you for having me this webinar and the panelists. Yeah, so I think the previous speakers have emphasized the need for some form of regulation and coordination from nationally in terms of supply to make it smooth, especially because the logistics involved with radiopharmaceuticals is not like any other pharmaceutical. We are dealing with a physical half-life which we don't have control of. Yeah, so we've been doing Theranostics for some time now, initially with mainly Abidemi, but from last year we started lutetium, both PSMA and DOTA therapy. And in Kenya we have two main bodies that kind of regulate or coordinate these services. One is the Kenya Nuclear Regulatory Authority, KNRA, and then the Pharmacy and Poisons Board, which basically is looking at all medication that is coming into the country and how it is utilized. So we've worked with those two bodies to, first of all, get approvals for doing these treatments, and secondly, to help expedite processes of especially clearance from the airport, because that can be a rate limiting step. Luckily, they have been very helpful. We've not had any untoward event in terms of a radioisotope decaying at the airport just because of delayed clearance, just because we have informed them prior. They know about these treatments, so they know about the clearance that is needed. Of course, there are other government clearances that may be needed depending on each country regulations, things like stamp duty related to your tax. Best from our experience is to have a pre-clearance or pre-authorized clearance prior to transportation of radioisotopes that have to be used within a short time, so that there is not much significant delay. The other thing that has helped us is we have a few radiopharmaceutical supply agencies or companies that work with the international suppliers. So some individuals have set up private companies that help with the process of both importation and clearance. And that helps in the sense that the hospital is not, or the individuals that are offering the treatment are not directly involved in the process. Yes, I would say those have really helped. The other thing that maybe just to mention is what we have noticed that also helps is to try and lump patients together. Because clearances are easier if they're done. You don't want to be doing one clearance today, another one tomorrow, another one next week on Monday. It's easy actually to just lump patients because it's not an emergency treatment. It's a scheduled treatment. You can lump 5 to 10 patients for every week. So you have your iodines and lutetiums coming in the same kind of at the same time, so that the clearance is more smooth and more efficient. Yeah, thank you.
Thank you very much, Professor Ali-Gombe.
Thank you very much. I think the nuclear supply should not be left to individual hospitals. It should be actually, there is need for a coordination, mechanism whereby Federal Ministry of Health, NICRAT, NIAC, and NNRA are all, in the picture of what is happening and also well coordinated. That will ensure that, the centers get timely medications, as at when due. What do I mean by that? Federal Ministry of Health is the responsibility of having policies, and I think that we have comments with respect to that, in the sense that the Technical Working Group for Nuclear Medicine has been available. They have also worked on the National Policy for Nuclear Medicine, which has also been launched this year. And then NICRAT is supposed to provide a strategic direction and leadership, in the sense that also assess what we need, where do we need it, and how does it come. And I know the source, also expertise and everything is supposed to come from NIAC. And then, of course, the regulatory framework from NNRA. So these things are ongoing. What we need to do is just to bring all parties together and make sure that we have timely supply of these radionuclides, and at the same time works towards local production of these radionuclides, which I think NIAC has been doing some work in terms of having to make sure that we have a nuclear reactor. And also, as NICRAT, we have also been trying to get cyclotrons and other nuclear medicine equipment across the country, so that at least we can have some coordinated supply for some of these radioisotopes. So generally, what is important as a national strategy is actually the coordination and involving all the stakeholders. Thank you.
Thank you for that response. We're happy to hear that work is going on, that you're planning to expand this across the country. So that's very good to hear. There's a question I have, and I can also see another question in the chat. So I'm just going to tie the two together. It's around the issue of financing. How do we plug in radioligand therapy into the current cancer financing health fund or budget? I don't know what exactly it's called. I stand to be corrected, but how do we plug that in, Professor Ali-Gombe and Professor Omonisi, NCS? So does my question make sense? We currently have a National Cancer Health Fund that covers treatments, I believe, radiotherapy, chemotherapy. So how can we now, radioligand therapy, how do we get that into the cancer budget, the Cancer Health Fund, the Cancer Control Plan, all these other existing plans and funds? How can we do that? The how? As soon as possible. Because it's a very expensive treatment. It's very, very expensive, more expensive than, yeah. So.
Thank you very much. I think we need to look at short term to medium term and then long term when it comes to financing of some of these things. One is that in the immediate, we need to look at existing programs, that are available and leverage on them. The existing program, of course, is the National Cancer Health Fund and the Nigerian Cancer Access Partnership Program. The Cancer Health Fund provides services free of charge to patients. The only thing that needs to be done, as long as funding is available, is just for us to, for NICRAT now to approve that radioligand therapy is also part of the National Cancer Health Fund, but nothing more, just some paperwork, and then it will be provided. And however, we also need to look at other services because not everybody that will be on the National Cancer Health Fund. So the Cancer Access Partnership Program, which provides anti-cancer medicines at a discounted rate to patients, which will also likely cover more patients, is also another alternative that we can include into the program. So we can have a nuclear medicine access program, which can also look at the radionuclides and how we can make them accessible and affordable to our patients. The other aspect, which is very critical, it's actually, for universal health coverage, which is the ultimate goal when it comes to, cancer care and generally healthcare in this country. We need to get everybody under insurance as time goes on, which is a long-term plan. And I think the NHI is also doing well in terms of, increasing the numbers, to a significant level now. I think we're about around 50 million Nigerians or so. So what we need to do is to make sure that, all these things are also covered on the long term on insurance so that patients don't need to pay out of pocket, and that will ultimately solve the problem of financing and other things. But having said that, we also need to look at the other aspect. That is, the government cannot do this alone. We need to look at other structures such as PPP in order to even provide these services, or even encouraging more private organizations to come on board in terms of nuclear services, so that we both have government-owned PPPs and also private organizations rendering these services. And then this can also be coordinated in such a way that we can have some, the access programs, the cancer funds reaching the PPP and private sector to encourage them also to venture into these services. Thank you, and over.
Okay, thank you. Professor Omonisi, quickly.
Yeah, I think except we want to deceive ourselves, the way to go now in cancer management is targeted therapy. People have used the traditional method over the years, and we've not seen dramatic improvement. I've mentioned earlier on that we have this thing already captured by national policy. What we need now is the goodwill and the support of the government. Usually, once there is a will, there will always be a way. I actually have this mentality of everything is possible. If you can mature your case, appropriately. We have the national platform, to get that done. Just to get that incorporated. If we have Cancer Health Fund, talking about treatments, what we are talking about is also a form of treatment. So it's a matter of expanding, what we have, and we also know that government can also do social intervention, as the case may be. What's most important is for us to put our hearts together and see how to get this thing, channeled to the appropriate authority. You need a well-articulated memo. You need to pay cost efficiency where necessary. You need to carry stakeholders, along. For the CSO, we continue to advocate. I want to have the CSO struggling in support, like Nigerian Cancer Society and other, affiliated organizations, and also the professionals, and of course the regulatory agency, NICRAT, Forums of Health, and others in support. I think that it shouldn't be a difficult situation. We know that we're in the circle of budget now for 2027. Although we have some challenges with previous budget, but at least is also an opportunity, for, NICRAT and Federal Ministry of Health to also, make this a priority. Say that once they make it a priority, there's no time that funding will be enough, particularly in developing country. Matter of government making a priority. We know the politician, if they make something a priority, the money will come out. It's a matter of executive order. So we need to play our card, in a very right way as stakeholders that very concerned, and get people in authority to key into this vision. And once that is done, once they see it as a priority, funding will come. That's the truth. Funding will come. We see, during COVID, for example, post-COVID, how the federal government of Nigeria roll out billions, to support the airline, and they said it's to support them, but the best of my knowledge, and I'm not sure, those money were paper. So sometimes just they have billions to capital project because they see our priority. So I think we should make this a national emergency. Let government see. Cancer now is not a disease that somebody can hide. The poor die of cancer, the rich die of cancer. It's not a disease that the politician and people in government will say they are not aware. Some of them actually have cancer. That's the truth. And once we can let them know that what we are talking about is the latest intervention in the world that can really help reduce mortality. There's an improvement over the traditional chemotherapy, and this will lead to improvement. It's evidences. Of course, there are evidences. We may not have the publications that have shown that this has an edge over the traditional way of management. I'm sure that they will keep to it. And the good thing about it, we have the government and people in authority that are very listening. The minister, the permanent secretary, there are people that are very keen in seeing innovations, new development in a cancer space in the country. So I think we shouldn't have any problem getting this done. But as I've said, practitioner, government organization, agencies, SADU regulation, in this regard. And of course, cancer survivor too, can also not neglect them. Must come together, work together, and see how to marshal this to government for prompt intervention. Thanks, Anova.
Thank you, Professor Omonisi. Thank you so much. Dr. Akintunde, we're talking about creating awareness, but when we talk about awareness, we seem to refer to public awareness. But even amongst health professionals, amongst the oncologists, clinicians, do you think that professional and referral awareness for oncologists and other clinicians can become part of the advocacy agenda? It's a two-in-one. Let me ask my second question. So you have experience here in Nigeria, and now you're in the UK. Somebody's asking, okay, let me be sure I read this correctly. Okay, what are the bottlenecks to having more patients being treated by lutetium PSMA? So when you answer the question, I would like Dr. Nguku from Kenya to make his comment on his own experience, and as well as Dr. Rathod to also make his comment on from his own experience too. Does that make sense? Two in one.
That sounds like 4 in 1. So I used to work in Kenya, and Dr. Nguku can confirm this. I used to work in the second center. Dr. Nguku was at the leading center and still is the leading center. And at that time, as an outsider, there was competition between the centers. And I was like, what? You have 2 centers in the country and you're competing. You guys should collaborate. And now they're collaborating, and they're now a perfect example of how things should be. But when it comes to patients, nuclear medicine doesn't own patients. They come from the oncologist or urologist. And for some reason, these professionals tend to hold on to their patients. So, if I'm doing my clinical work, how much time do I have to go knock on the door to say, how many patients do you have who qualify for this? And many years ago, we did a survey among a group of clinical oncologists, and, you ask them, do you know about this? They say, yes, yes, yes. There's a difference between theoretical knowledge and then the real life application. And I'm sure most of the first patients we treated were individuals who walked in to say, oh, nuclear medicine, can you do this? Actually, the very first patient we treated in Nigeria, that was the case. There were patients we had sent abroad as well who were rich enough but just didn't want to do it locally. So there's the also health system. How would people trust the health system? There was a time you couldn't fly from Abuja to Ibadan because the airport was under construction. And the patient just refused to come and said, Doctor, I'll go anywhere for this. But Ibadan had put in systems to clear faster. And so it's there are many patients that we can treat. I think the awareness is layered, so they know about it, but in terms of understanding the benefits for their patients, I've had people say, oh, lutetium will just extend the life by 3 months or 6 months. I'm like, okay, compared to what? Have we looked at side effects? Have we looked at alternatives? And that's why the first lecture I tried to say, look, we need to have this conversation together to say who's the best patient for the best care. A patient who doesn't deserve lutetium should not get lutetium. If it's my father and he doesn't qualify, so be it. But it's a very good treatment. And that's why we see that the trend is for it to now even come higher in treatment. So I think collaboration is the key word here. And what's different is if there's a clear pathway and people are following it. So here in the UK, we still have the challenge because, interestingly, PSMA is not funded by the health system. So patients pay out of pocket. It's £20,000 for one treatment. And we have patients, we treat 2 patients every week. But for dotatate that's funded, we have an MDT. In fact, they're pushing the patients to meet quicker, and they won't say, no, let's be sure this meets a criteria. So once we spell out the criteria, which is well spelled out for neuroendocrine cancer, the patient must have failed on injectables, and they must have radiological progression. Even for PSMA, must not have lymph node disease bigger than a certain size. There must be this and that. So once the patients fall into that criteria, I expect the oncologist to say, oh, now this is time you go to Mayawa in Ibadan. This is time you go to Lagos or wherever the treatment is offered. So this thing of holding on to patients, it's something we need to just change the mentality. And with meetings like this, I'd like to go to the oncologist meeting to present. I'd like to go to the radiologist meeting to present. So we're not just doing nuclear medicine physicist meeting. We now need to break the silos and speak to them. But Dr. Nguku, tell us how you did it in Kenya. That's something very interesting.
Okay.
And Dr. Nguku, if you could answer, aside the oncologist not being aware, what other bottlenecks, are there or have you experienced to getting more patients for lutetium therapy? Just to add that to your comments. I want you to answer that in addition to what you're trying to say.
Yes, thank you. And I think I agree with Dr. Akin that we still have a challenge in terms of the process of patient referral. It's not as we would like, as if I put it that way. I feel probably awareness is not the biggest challenge with the oncologists in my country. Maybe there is a bit of reservation sometimes in referring the patients to us. But 2 things. One, within the hospital where I work, I think we have a very good multidisciplinary team, including specifically a urology or genitourinary multidisciplinary meeting that happens every week. So all prostate cancer cases, or at least most of them, are discussed in this meeting. And if a patient would benefit from lutetium PSMA therapy, for example, they would be referred to us. Same thing for neuroendocrine tumors. Lutetium dotatate therapy patients would be referred through the MDT. So that has really helped in terms of breaking that bottleneck of referral. From my experience now, since we introduced the service, I think the biggest bottleneck beyond, of course, not getting the patients referred is cost. And I know this has been spoken to by the previous panelists, but it's actually a very big hindrance to widening the access and the reach for lutetium therapies. On average, we get maybe 2 to 3 referrals a week but we are not able to go ahead with treatment for a lot of those patients just because they can't afford it. Our national health insurance does not pay for it. A lot of patients are paying out of pocket. A few patients have very good insurance cover that pays for them, but generally, majority of patients that would actually qualify cannot afford it. So that is a big challenge. We are trying to work with a social health fund to try and, even if it's not pay for the whole cost of the treatment, at least pay for part of it, because then a patient doesn't have to, cough out the whole amount. The other thing that we see, which I think might be a bit unique to our population, we see patients are referred at the very end. We know that now lutetium PSMA therapy has been approved for earlier use, including in metastatic hormone-sensitive prostate cancer in combination with ADT and ARPIs. But majority of patients that we actually get are patients with who have failed chemotherapy, patients with metastatic castrate-resistant disease, and some of these patients are actually very sick, and their ECOG performance status is very poor, so you don't want to treat such patients because you may actually not do more harm than good. So those, I would say, have been some of the hindrances. In terms of increasing awareness, I think we have been trying to do that through seminars and webinars. As Dr. Akin said, we see a lot of patients actually coming directly to us because they saw something that is available and they want to know about it. But I agree that we still have a long way to go and there's a lot of things to be done. Thank you.
Thank you. Dr. Rathod, quickly, do you want to make a comment before I move on? We're already out of time.
Sure, I'll keep it brief. Yeah, I was just going to add that I think those are very important things. Having a connectivity to the referring pathway is key because that is helping you create a linear path, and having a connectivity there in identifying patients. And to Dr. Nguku's point, is really just about knowing that, up to this point, the majority of patients getting lutetium PSMA-based therapies were receiving them after a cascade of other treatment avenues and then being referred. So I think now we're seeing with the data, it's more pronounced that the patients are faring better when this is used first line for the most part. And I think that more is to be told as the story unfolds. But I think that's an important distinction. Going back to the question about the supply, the national supply of how the drug is supplied is based on the regulation. In the United States, everything is provided by manufacturing, so we're restricted by ready to administer. The compound is radio labeled at the manufacturing facility. Other regions will allow you to radio label in-house. That is good and bad. It can give you some flexibility, but you have to be able to source both the molecule and the isotope, and both have to converge at the bedside within a short window. So I think it places that last threshold of delivery, getting it over the finish line, that places a little pressure there, but does buy you some pliability. So it's not further barriers upstream.
All right. Thank you very much. We are running out of time already, and I haven't even gone through 1/10 of my questions. I hope you can still hear me. It's raining heavily around me. But I have a question for Oncidium Foundation and for Medicaid, who are, the organizers of this program. So I don't know if Dr. Alice is the scientific director for Oncidium. So thank you, first of all, Oncidium. Oncidium has been helping to make, these treatments available at affordable cost to patients here in Nigeria and in Ghana, and I believe in Kenya too. But how can Oncidium continue to support the implementation of nuclear medicine treatments in these countries you've been doing and in new countries?
Hello, everyone. Thank you, Yobosa, for first of all for co-organizing or co-hosting this series of webinars that I consider it was a success. And we received some questions about trainings and how to become a radiopharmacist. As a radiopharmacist, I get very happy with that. But I need to tell everyone that Oncidium doesn't give trainings, or at least trainings that will be recognized as validated to work as radiopharmacist. We collaborate with some institutions like AIA and support their trainings. So it's not a training organized by Oncidium. We can support donating, for example, radioisotopes through our network.
Okay, I'm sorry, I didn't hear you clearly, but I believe the question was answered. Did you all hear? Okay, fine, because I can't hear very clearly again. Okay, so thank you once again for that answer. And it's not just for the radiopharmacists alone. There were questions even from other health professionals,
yes,
radiographers, the nurses, the physicists, the whole team wanting to know how they can, get involved, be a part of this. Okay, all right. So thank you, Dr. Zainab Bagudu, Our Excellency. The founder of Medicaid is here. Thank you to Medicaid for all that you have been doing. So how would, I believe you agree with me that the government cannot do this job alone. So as a private organization, if there are individuals or hospitals, organizations that would want to join or partner with you, with Medicaid, is this possible? Are you open to partnership and all of this?
Well, most definitely. Thank you for the question, whoever asked it, and to everyone involved in this. I believe that as a civil society organization, we're best placed to partner with different bodies. We partner with government, we partner with industry, we partner with professional scientists to ensure that we all reach the goal that we're trying to. And the advantage is that we are in a unique position in that we have a very wide network, as we have seen from the success, from the collaborative success of these webinars. We are able to amplify the message, and through our dealings with so many organizations across the globe, we're able to provide the opportunities that exist and bring them home to different healthcare workers. This webinar is a good indicator of that, and I believe that the success has been partially due to the way we've been able to network. So to answer your question briefly, yes, of course, we're ready to partner. We're very happy to partner with different bodies and scientists so that we can all achieve the greater good for cancer patients.
All right, thank you very much, Your Excellency. I'll be coming back to you, and I'll come back to Dr. Alice too. But we've run out of time and we couldn't go through the questions. I believe you would agree with me that we need to do this again. We need to have a part 2 of this. We need to continue to have this conversation. So I would kindly like to ask our panelists to just give a final word or remark. If there was something you wanted to say that I probably, because of time, we didn't have the opportunity to ask the question, or speaking from your organization like NICRAT, NCS, from Kenya, from Ghana, US, what would be that final word you would like to say to us before we close out on the session? Maybe I'll do the roll call. I will start from outside and I come within. So maybe start from Dr. Rathod, our nuclear pharmacist. Your final words. There's one burning thing you would like to say.
I think we touched on it, but I think for me, one of the most important things that I'm hearing is, I think it just echoes that we cannot do it alone. I think we have to partner with our counterparts in other countries, other partners within our nation and beyond. And I think coming from Kenya, there's a proverb that comes to mind. It's like, if you want to go far, go alone. If you want to go fast, go alone. If you want to go far, go together. I think the only way is together.
Thank you for that closing statement. Dr. Nguku Samuel.
Yeah, I think in addition to the issue of collaboration raised by Dr. Rathod, I think we need to make ourselves felt in multidisciplinary team discussions I think we are now past beyond the just presenting images and diagnosis to offering treatment options for patients. So I would encourage centers that don't have MDTs, if you're here and you're an oncologist or a nuclear medicine physician, very important to have MDTs, because I think though they offer the best, setup for patient treatment, so that the patient is discussed and offered the best available treatment without being biased by a specialty. So my partition is, collaboration and MDT discussion of all patients, so that they offer the best available treatment. Thank you.
Thank you very much, Dr. Akintunde Orunmuyi.
Thank you. I'm going to task Professor Ali-Gombe that we've learned from Kenya how they organize KNRA, the pharmacy board. We have the same. We have NNRA, we have NIAC, we have the Pharmacy Council of Nigeria. I want to ask you, get NICRAT to call them and to call the Ministry of Health. Dr. Uche, he was meant to be here, he dodged it. So let's have a sit down. It's nice to have these working groups, but nobody is a faceless thing. There's 16 members. If you talk to all 16, they will probably say the same thing, but nobody champions it. And I think that's the one thing we all didn't say. In Kenya, they would have had an oncologist who was the champion, who was like, I want this, and then everybody follows. So we need to find those early adopters, and I want NICRAT to champion this. You have the infrastructure, you have the mandate, you have the registry, it's also under you, so we can have a radioligand therapy registry. And you're close to Her Excellency, you're all in Abuja. For me to enter Abuja, I need a visa. So if I get to Abuja, where will I stay? If you come and give me your house, I'll stay. I can come and stay in Abuja for 2 weeks and be knocking on your door every day. But we want to give you this task to do it for us. I'll be very grateful. Thank you.
So that's your closing. You just fired shots at NICRAT and claim that you're no longer in Nigeria. You need a visa to travel to Abuja. That's your closing.
It's only Abuja. I can enter Lagos even I can enter Kano. But that's Abuja. Once you just enter, it's a different place.
Okay. I'm happy you're the one that set NICRAT up and NCS. So Professor Ali-Gombe, please fire your shots back to Dr. Akin. Then I'll go to the NCS president.
Thank you very much. Instead of firing the shots, I will take the bullets and make good use of them. So, what we need actually is we need to build systems. We don't need to allow it happen as the way it is, while individual hospitals are the ones catering for themselves. We need to embed the radionuclide policies and other things around nuclear medicine into the cancer control policies and implementation, which we have also be doing that. We also need to, have a supply and referral system. We need to have a definitive pathway for which these radioligands will come, and also the referral pathways for the patients that need them. And also we need the data. So we need to keep records so that we will be able to inform future policies and implementation, and also justify why we need to invest heavily in these programs. So by and large, as like I mentioned, we will just take on this challenge and also embed it into all the activities that we are trying to do. Thank you, and over.
Thank you so much, Professor Ali-Gombe. Professor Omonisi, President of Nigerian Cancer Society. Can we have
Thank you so much. Thank you so much. My parting word would be, as a practitioner over 25 years in our country. I think we shouldn't blame the government regulatory agency. The truth is that NICRAT, Federal Ministry of Health, largely depend on which practitioner implement many of their policy. And to be fair to them, more often than not, they seek our counsel, views on their various positions, which we have been doing. But the truth is that we must talk to ourselves as practitioners. People defend their territory. There is this professional rivalry. I remember when clinical and nutritional oncology came into being in Nigeria, the surgeon, surgical oncology, refused to give them space because over the years, the surgical oncology have been treating and administering chemotherapy, doing the work of regional clinical oncology. It was a serious fight in the country, both at the postgraduate college and also in the hospital. In fact, it was even recently that the regional clinical oncology were actually given a faculty at the National Postgraduate College. They were under radiology. Can you imagine? So we have that issue in our country. And I think that we must talk to ourselves because I know that implementing this in the country, having the national scale up, there will be some pushback from some quarters. I can guarantee you that. Because there are people that believe that they manage this patient using this conventional way, and they think that this will be working. You want to bring this to displace of transactional job, So this territory control mentality that some people have, must be dealt with. And how to, address that is that I think there is need for a national convention on this or summit on this. The regulatory agency, firms of NICRAT, can convey national, not necessarily physical meeting, but that may be expensive, maybe a virtual meeting, where presidents of relevant authority, society are invited, where key stakeholders, are also invited, we can have a national discussion. Let people see this, that the bottom line, what we're talking about, so the interest, of the patient. Better management of patients, also scale up our level of practice in the country. Unless that is done, so that everybody will be on the same board, and we cannot advise the government. Of course, the government, the regulatory agency, both firms of Ministry of Education, cannot, make appropriate amendments to various existing law to say, okay, in view of this, so profession, practitioner, this is your limitation, so profession, limitation, and that. Without that, the pushback that we saw between the surgical oncology and regional oncology, they probably will not allow this thing to have a national adoption. Thanks, Anova.
Wow, thank you so much, sir. This is a very serious issue you have raised, and it's not really common to Nigeria. We really need to have this discussion, maybe at the modular level. So amongst the specific health professionals, but it's a very important issue that you have raised. Thank you so much. Thank you to all our wonderful panelists. Thank you for accepting our invitation, and thank you for the comments you have made, sharing experiences from Nigeria, Ghana, Kenya. We would like to continue to have this conversation, but because of our time, we need to round off now. And in order to do that, I'm going to invite our partners, Oncidium and Medicaid, to give their closing remarks. And Dr. Alice Viana, the Scientific Director of Oncidium, will give in a closing remark, after which Her Excellency Dr. Zainab Bagudu would close out for us on behalf of Medicaid Foundation. So Dr. Alice, can you please quickly...
Thank you. Yes, I'll be very quick. I already thanked for the partnership, and this will be the beginning of a long-term partnership, I believe, and also for this discussion of the implementation of radioligand therapy in Nigeria, together with Dr. Akin. We will continue that. It will not be this single webinar, but also that's why it's so important to have all the stakeholders here. And I will pass the word to Dr. Zainab. And thank you once again.
Thank you so much, Dr. Alice. Her Excellency Dr. Zainab.
Thank you so much. Thank you, Yabusa. I believe we've said everything we need to say. My role now is to thank everyone that has been involved in this, our partners on CDM, our partners, Nigerian Physicists Association, of which Yabusa has really played a fantastic job as the moderator of the 3 sessions that we've had. I believe we have achieved a very reasonable level of success. We have been able to bring together panelists and real experts from across the world, using our own networks and minds from both parts. Excuse me. And this has shown us how partnership, if we make it work and we come together, can really make a difference. We haven't expended huge amounts of money, but we've been able to build capacity and share information and knowledge through these webinars. Radiotheranostics is a part of cancer therapy and diagnosis that many people are unfamiliar with. And one thing that kept coming up in the course of these webinars is the need to create more awareness and educate both the general population as well as the healthcare workers that are involved in treating cancer patients. So we hope that these series of webinars have helped to do that, and we commit to doing more in terms of spreading the word. Another issue that has come up all the time is the training. And although Dr. Alice has spoken to that, I want to say that we will work together to explore how we can provide more training opportunities, particularly for those who have already done their first degree, just professional, continuous professional learning with partners like NICRAT. And of course, we have our learned colleagues from various institutions across the world, the UK, the US. We'll be very happy to see how we can facilitate that. Just count on us as a very willing partner to do this. So thank you very much to the team at Medicaid, Oncidium, and I look forward to the next steps and what will come out of this. Thank you.
Thank you so much, Dr. Bagudu. Thank you for opening your doors up to have this conversation. So Medicaid was representing the entire country, in this partnership with Oncidium to provide this. Thank you. And thank you for the commitments you have also made. I know that you are someone who, if you say you're going to do this, you're going to do this. And with your position as UICC at the presidency level, I believe that these conversations we've had will not just stop here, but we are actually going to come up with very tangible, workable action items in the shortest possible time, with NICRAT, NCS, and our colleagues, of course, from Kenya, from Ghana, from the US, from the UK, and all over the country. So thank you once again, Dr. Zina Bagudu. Thank you, Medicaid. Thank you, Oncidium, for putting this together. Without you, this would have not been possible. Thank you so much. Thank you once again to our panelists. Thank you to everyone who has joined us. The recordings for the 3 sessions will be available. I think you need to go back and listen to them. We will send them even to our panelists so that they can be brought up to speed to some of those intricate discussions that came up in the last 2 sessions. Please, it will be sent to you by Oncidium Foundation. And as I mentioned earlier at the beginning, that you are entitled to receive a certificate of attendance. This will be made available by Medicaid Foundation. If you would like to have that, you need to write to them. Communications at Medicaid can cancerfoundation.org, and you need to do that by Oncidium with Medicaid to know what is going on, training opportunities and summits like this that will come up in the future. You can visit their websites, and if you can't scan the code, please put the link in the chat. Oncidium and Medicaid, please put your website link in the chat so that people can go and find out more about you. Thank you once again. Thank you on behalf of the Nigerian Association of Medical Physicists. We moderated this session for you, and we hope that we did a good job. So thank you so much.
You
and let me hand over to Faith. Is she here behind the scenes? Okay, so I'm handing over to Oncidium again. I don't know if there's anything else you want to say, but my job is done already. I'm done.
It was a great job. Very well done. Okay.
Thank you very much, Dr. Yobasa. You were brilliant in all the 3 sessions. We keep in touch.
Thank you. All right. So it's bye-bye from our end.
Thank you.
I think panelists will have another discussion of it to continue at the back end. Yeah. So we'll leave this meeting and continue to fire the shots, but it's all for good, like Dr. Professor Ali-Gombe said. We'll take the bullets and make good use of them. So bye-bye, everyone. Thank you so much.
Bye.
And if you have questions, please send them to Oncidium and Medicaid, please. I'm sorry we couldn't take all your questions, but the conversation does not end here. Please send an email to Oncidium and to Medicaid Foundation, and they will direct your questions to the
I will put my email in the chat.
All right. So
Dr. Akintunde, you're welcome. We'll give you a room to stay in Abuja and a visa-free entry. Visa-free.
Abuja.
No, I don't support that. I don't support that. Let him stay in the He ran away from here. Let him remain there.
No, we need him. We need them to come back. Always visa-free, no problem.
Thank you. Thank you so much, Mark.
Yeah, thank you. Have a wonderful day, everyone.
Thank you.
Too.
Yes,
Bye.
thank you, everyone. Thank you. Yes, bye-bye, everyone.